Last 15 years engaged in research and policy analysis to promote a better, more fair healthcare system for consumers and for patients. For those of you unfamiliar with the center, we are a team of national health policy experts. In addition to our research publications and policy analysis, we provide technical assistance to state and federal policymakers. While we have historically focused on commercial health insurance, we've recently learned and become aware that there is a real lack of nonpartisan, independent policy research analysis voices for the Medicare policy conversation. Yet, at this time, couldn't be a greater need for those voices. We have looming big debates over financing, Medicare Advantage, prescription drugs. Folks on the Hill, in the executive branch, state officials too, they need voices that are independent, evidence-based, and consumer-focused. And that's where we're going to come in. We are going to take CHIR's longstanding approach to policy research, analysis, and technical assistance, and use that to contribute to a better, more informed, more beneficiary-focused Medicare conversation. So that is why we're launching this Medicare policy initiative and why I couldn't be happier to introduce you all to Carrie Graham, our Executive Director of MPI and a national expert on Medicare and aging policy. Carrie, why don't you come on up?
Good morning. Good morning, and it's wonderful to see so many people so early in the morning here to talk about Medicare Advantage. So I hope you all got an extra cup of coffee, and I just wanted to say thank you, Sabrina, and it is a real honor to be here to start this new Medicare policy initiative to build out and build on the approaches that the Center on Health Insurance Reform has created such a great reputation in the work that they do. The Medicare Policy Initiative, we're just getting started, and I want to thank our funders who are here today, West Health and Arnold Ventures, for trusting us to start in this endeavor. And so we're trying to build on CHIR's great tradition of using some of the same approaches, like research translation, policy analysis that's unbiased and nonpartisan, technical assistance to policymakers, and convenings like this, to be able to look at Medicare and especially Medicare Advantage as it becomes a more popular program, to look at what's working and to focus on coverage, making sure that Medicare beneficiaries have the best coverage possible. We'll be looking at costs, not just costs for beneficiaries, but costs for the program overall, and making sure we're providing meaningful choices for beneficiaries. So with that, to do all of this, I can't do this by myself. I want to introduce our amazing team that we've put together at MPI. First is Dr. Jack Hoadley. You may know him as a former MedPAC commissioner. Where are you, Jack? There you are. Go. I have these new progressives on, and I can kind of see different things. Jack is he's an emeritus research professor, former MedPAC commissioner, but you should also know that he, in his spare time, volunteers with the SHIP program, helping Medicare beneficiaries to figure out their Medicare choices. We also have Dr. Rachel Schmidt, also a former MedPAC staff and a SHIP volunteer in her spare time. We also have Lila Sullivan, who is our research fellow. Lila, who helped put today. There you are. She's behind the screen. She's hiding. Madeline McBride is our graduate student. There she is. And last but not least, we have Neil Patel. welcome Neil, because he is, this is his second day of work, and he and I worked together way back when on the Ways and Means Committee, and he is coming to us from CMS, Office of Legislation. So really thrilled to have this great team around us, and if you get a chance after the session, make sure you say hello. So let's talk about Medicare Advantage, and let's talk about prior authorization and how plans use utilization management. I have this slide up, not because everyone doesn't know that Medicare started in 1965 with the Social Security Act, but more to say Medicare is an evolving program. It's evolving all the time. In 1965, we had a program where it was health insurance for the elderly, hospital insurance, which we now call Part A, and optional outpatient insurance, which we call Part B. In 1970, it expanded to some younger populations with disabilities. And back then it was fee-for-service. Your doctor prescribed a treatment, and the federal government paid the doctor. In 1997, the Medicare program decided to try a new system where they had private health, to give people the choice, Medicare Plus choice, to give people the option to enroll with a private health plan who would use an HMO or a PPO to administer all your Medicare benefits in a managed care system. This didn't really get going or take off until about 2003 in the Medicare Modernization Act, where we remember Part D started then. Thank you, HW. But we also had increased payment, and the program really took off to what we have today, which is over half of Medicare beneficiaries choosing a Medicare Advantage plan, an HMO or PPO, a private plan to administer their Medicare benefits. And there's still some differences that are really important. Medicare, traditional Medicare, as we call it now, is still fee-for-service. There's some problems with fee-for-service. Problems that we've always been worried about, that it doesn't provide an incentive for providers to pick lower-cost care even when that care is equally effective. It can encourage low-value care where the harm or the cost outweigh the benefits, and it can encourage things that are higher reimbursement. But beneficiaries who are in it have a lot of choice. They can go to any Medicare provider. If they have a rare disease and they live in Oregon, they can go to Minnesota to the Mayo Clinic to see the one doctor who is a specialist in their illness. And they don't need a lot of prior authorization. Their doctor prescribes something, and for the most part, they get it. In managed care, just like any other managed care plan, most of us probably have HMOs or PPOs, and it's based on a capitated payment, where the federal government looks at a member who is enrolled in a plan and pays that plan a per member per month rate based on their diagnoses. They then have this financial incentive to reduce utilization, trying to reduce things like low-value care for the beneficiary and promote high-value care. But there are some trade-offs, especially for the beneficiary. For the most part, limited provider networks. You have to see inpatient providers, which can be issues in rural areas especially. And we get into the situation where care has to have prior authorization. They use utilization management. So you have the situation where beneficiaries and their providers are getting prior authorizations, denials, appeals, and the whole process. Why do beneficiaries choose this if it has these trade-offs? And I would say the main thing is cost. We know that MA plans can cap out-of-pocket costs. It's a lot more predictable. In fee-for-service, you are not going to have your costs capped unless you also can afford a Medigap plan. And they have lower premiums and cost sharing. So I think really that is when people call Jack or Rachel and say, how do I reduce my spending on Medicare? That is what they are learning. They also can provide extra benefits, and you see in advertisements for Medicare Advantage that they can provide dental, vision, and hearing in a limited way, and some non-medical benefits that traditional Medicare doesn't cover. And so things like gym memberships or transportation or even groceries. So those things are all very appealing. And I think that's why we see about half of people are choosing it. But there's problems. It used to be you would have heard about some of the problems in things like prior authorization for beneficiaries if you're reading health news or health journals. But now if you're reading the Washington Post, you will see situations where MA plans are being scrutinized for denying necessary care, people coming to harm for care being denied or delayed due to the lengthy prior authorization process. We're also hearing a lot of burdens of the providers and health systems, spending a lot of their time working on appeals and denials of care. And lots of providers are exiting. Lots of health systems, I think 25 health systems have exited MA plans, which hurts beneficiaries. Finally, I'd say from a beneficiary perspective, beneficiaries going through, a health crisis and having to deal with the complex appeals and denials process. I think we can all relate that can be a really difficult thing. The good news is there is bipartisan support for change. We have had, the CMS has finalized rules that are trying to fix some of these problems, speeding up prior authorization, reinforcing MA plans to say you have to provide the same benefits as traditional Medicare, and other protections to avoid disruptions in care. We have a fact sheet as a companion piece to this session today that has a lot more detail there. CMS also has proposed rules that are yet to be finalized, but if they're finalized, they will add a lot more protections. And we have some bipartisan bills with Republicans and Democrats signing on to things like Timely Access to Care Act for seniors. So we will see what happens with all of those. Our team also has published a compendium of MA and Part D proposals. We aren't really talking about Part D today, but lots of proposals that are out there to try to improve the program. So with that, again, we agree on a lot of things. We agree that beneficiaries should have the right to timely care and state-of-the-art care. We agree that we need cost containment. It's one of the biggest budget items, and none of us want waste or to deplete the trust fund. I think we can agree that we need to balance the interest of a lot of important stakeholders here in the MA program: the federal government, taxpayers who are paying into this program, Medicare beneficiaries who've paid in and now need their benefits, as well as the Medicare Advantage plans themselves and the Medicare providers who are giving the care. So trying to say there is this, one of the reasons we wanted to talk about this today, because there is agreement on this thing. There is room for movement even in this time of transition. So that's what we're hoping to get to today in our expert panel. And with that, I want to introduce our expert panel, starting with Dr. Edward Hu from, if you want to come up when I introduce you, you can sort of wave on your way up. He's the Executive Director of Inpatient Physician Advisor Services at UNC Health in Chapel Hill. He's an internal medicine doctor, and he practiced as a hospitalist at UNC Rex Hospital. He co-founded the Physician Advisor Program at UNC Rex in 2012, and is an expert on utilization review, compliance, revenue cycle, quality measurement, and clinical documentation integrity. So we're glad to have you here, Dr. Hu. Eddie, he told us to call him Eddie. We're also going to introduce Fred Riccardi. You all probably know Fred. He is the president of the Medicare Rights Center. As Vice President of Client Services, he oversaw all of Medicare Rights client programming, including its national helpline, which handles around 20,000 questions from Medicare beneficiaries each year. He's also worked with programs, including 2 new ombudsman programs for New Yorkers with specific health needs. Welcome, Fred. And finally, we have Molly Turco. Molly has over 15 years of experience working in Medicare policy issues. Just this January.
17.
17, so 17 years.
No, 17th of January.
Oh, the 17th of January. She left her role as senior advisor on Medicare Advantage and Medicare Part D advisor at CMS. So welcome, Molly. And Molly has spent the last many years working with many of the stakeholders and listening to many of the stakeholders that we mentioned earlier who are all part of this process. So welcome. All right. Thank you all for being here. We're just going to start with a few questions that I'm going to ask our panelists, and then we'll have some time for Q&A. And Fred, I want to start with you because we always like to start from a beneficiary perspective. With the experiences that you have had with the 20,000 people who call you and ask for advice, talk about their issues. Let's talk about the rules that CMS has finalized and the proposed rules. Many changes, many attempts at protecting beneficiaries in the last few years. So what do you think are some of the changes that will be most helpful to beneficiaries themselves? And I'd like to hear from you, what's next? How do we build on those? Remember, this is an evolving program.
Great. Everybody can hear me okay? All right, excellent. Well, thank you, Carrie, for inviting me today, and congratulations to everyone. And of course, thank you to West Health and Arnold Ventures for supporting this initiative. It's extremely important. I do want to mention, similar to our work at the Medicare Rights Center, we have a helpline. We field calls from people. Over the years, increasingly, we're counseling more people on Medicare Advantage. And that's what I love about the work that Jack and Rachel, that you do, is you have deep policy research and expertise, but you're also volunteering your time as SHIP counselors. That's extremely important. And so when we think about the stakeholders that are impacted by Medicare Advantage and really focusing in on prior authorization, I like to step back and think about the journey of the Medicare beneficiary in centering the beneficiary amongst all of those stakeholders. And I think there's 5 core concerns that relate to prior authorization, and I think the most recent proposed rule kind of gets at some of that, and then some of the final rule from the last couple of years. First of all, most people who are new to Medicare expect Medicare to be very affordable, accessible, easy to understand, and navigate. So from that moment, people aren't informed about their enrollment. Most of the information they get is from Medicare Advantage marketing. And so from that point, there's a lot of confusion. And then let's say someone decides to choose the coverage path of Medicare Advantage. Maybe early on, or maybe as they age and develop a chronic condition, they then may encounter a problem with prior authorization. And that usually then manifests itself in a denial. But it's not clear cut. You just don't get an email or a notice. Typically, you're working with a physician and you have trouble understanding, well, what happened? Why is this denied, et cetera. And there's a real lack of clear communication, although this is getting better. And previously, it would say, this service was denied due to CFR, XYZ, number this and that. It was very confusing. And then you enter into, or actually most people do not enter into a broken appeals process. And so that's kind of where the very obvious data is there. You have 6% of services in Medicare Advantage are denied for prior authorization, and then most of them are overturned. But what we know is that very few people appeal. So that's really where we need to dig into. And so the recent rules, the proposed rule, they increase transparency. So that's great. There's going to be more data collection. I think one thing lacking in the current proposed rule is we really need more plan level data because we need to get at the decisions that are being made. In New York, we have a very small demonstration. It's called the Integrated Appeals Process. It integrates Medicare and Medicaid services. And the data that's collected is limited, similar to Medicare Advantage. But since the Integrated Appeals Process is different and it goes into the Medicaid fair hearings, both Medicare and Medicaid services, there is data out there with the research. And so what you see, 90% of the denials are for Medicaid services. 88% of them are for the most costly services. So I think we really need to get into the plan level data, and that's one thing lacking. I think, and Eddie can probably speak to this, there's improvements on providers, being able to submit prior authorization more easily. And so I think there's some good stuff happening. I think there's more that can be done now.
Yeah. Eddie, let's turn to you. From your experience as a provider and an unusual provider who's a policy expert as well, you're in a large health system. So what are some of the trends in utilization management and prior authorization that you're seeing that you'd like to elevate, maybe that haven't been in the headlines and in the news? And your suggestions for approaches to address some of these.
Yeah, and I definitely appreciate the opportunity to be here. And I don't spend a lot of time in Washington, and those in the room are far more than I do. So I think what I can bring is my perspectives in working for a large healthcare system in North Carolina, and I think that's probably what you all would find most valuable. I'm not an expert, Fred, in the prior authorization rules and the application program interfaces that are being developed. But I understand that there's a lot of promise to simplify the prior authorization processes with those rules that were finalized, I believe, last year, and that will go into effect, I think, in a couple of years. So we're eagerly looking forward, because one of the items that I do hear frequently from our providers is that we don't know what needs prior authorization. Our EMRs do not contain the plan-specific information to know what requires prior authorization for the patient that we're seeing in front of us in clinic today. So definitely looking forward to some technological improvements there. What I am going to focus my comments mostly on is the hospital-based services, because inpatient hospital services comprise approximately 33% of the cost of the Medicare expenditures. And of that 33%, about 3/4 of that 33% represent inpatient services related to urgent and emergent services. These are services where people don't plan to come to the hospital, like, oh, I've got an appointment to go see my hospital, in 3 months, or I'm going to be admitted to the hospital in 3 months. I mean, we know that just doesn't happen, and the hospital is the last place that people want to be. However, the approximately 25% of Medicare expenditures that are spent on inpatient care for urgent and emergent services is also subject to prior authorization requirements. And so that's, I think, the perspective that I can share that may not be completely evident to everybody in the room. So if you take, for instance, a patient who has a newly diagnosed cancer and needs a surgery to remove the cancer, or maybe the cancer is known, but the patient has become acutely symptomatic from the cancer, that patient needs to have some sort of procedure to either attempt to cure the cancer or to alleviate the symptoms that are occurring from the cancer. When those things are diagnosed and seen in clinic, you want to get that patient in as soon as you can. Right? These are processes that need to happen within days. The doctors, the hospitals, the OR time, the availability of the beneficiary, those are all things that need to be coordinated and coordinated quickly. And I will say that the Medicare Advantage plans in our area really try their best to not let prior authorization hold up urgent services such as this. I mean, they really do. I mean, it really is a collective effort. But what then happens when the day of surgery arrives and there has not been a decision on approval for the procedure that's needed? Do you move forward with the procedure, which is what I think most providers would end up doing, but then you sort of lose the assurance that the payer feels that it's medically necessary? What do you do? If you take another situation, which is somebody who comes to the ED with an acute pneumonia and needs hospitalization, that patient will also undergo a utilization review for the appropriateness of the inpatient stay. Now, that is no longer prior authorization because it wasn't scheduled, and by the time that the hospital knows that the services are needed, and by the time that certainly the plan knows the services are needed, they've already started. But yet there is still a authorization process. I guess I shouldn't call it prior authorization anymore, but a concurrent authorization process that then occurs. And if a denial is issued, that denial may come concurrently. It may come actually after discharge because the care is ongoing. And currently there is a relative lack of ability for members and network providers to appeal denials of inpatient care that start as emergency services, as emergency medical conditions. And then after discharge, CMS currently does not provide a route for CMS appeal for those inpatient denials. Now, there are some proposed changes in the 4208 rule, but they're not yet finalized. The last thing I want to mention before I yield back to the moderator is that as patients near discharge, from the hospitalization, they frequently will need some sort of post-acute service, whether that be acute inpatient rehab or subacute rehab in a skilled nursing facility. That service, too, requires prior authorization, and it's not uncommon for several days or even a week to elapse while the patient remains in the hospital waiting to see if the services will be authorized or not. The MA plans in our area require us to identify an accepting facility and to have a bed available, and that patient, if fee-for-service Medicare, would be able to go that day. But for Medicare Advantage, that then becomes the start of the authorization process that can then take several days and subject the patient to unnecessary risks of prolonged stays in the hospital.
Thank you, Eddie. Molly, let's turn to you. Utilization management and prior authorization, they've come under a great deal of scrutiny. I know that you have been working with policymakers, different stakeholders, and the general public. At your role, you hear the perspectives of all these different stakeholders. So can you tell us a little about what are the trade-offs in prior authorization at MA that have to be weighed? It's not just something that you can get rid of. What are the trade-offs there that we have to think about in terms of the beneficiary, providers, and plans?
Thanks, Carrie, and thanks for having me. This is a great conversation to be having, very timely. As you know, just left my time at CMS. Before that, I worked at Blue Cross Blue Shield Association and with Better Medicare Alliance, so worked kind of in the MA plan world. So really approached this knowing kind of the pain points and perspective of MA plans. And then, as you said, Carrie, at CMS, we heard from all stakeholders, so plans, but definitely providers. Eddie was very helpful hearing about really that nitty gritty in the weeds of the day-to-day and the impact that's happening. Provider advocacy groups, we heard from a lot of beneficiaries themselves. And I think it was clear that we're hitting a tipping point right now. And I think that part of it is just Medicare Advantage in general. I think, however, a decade ago when MA was like 25% of MA, it wasn't as much in rural areas. I think a lot of these concerns existed, but there wasn't as much volume. And I think that we at CMS heard a lot from rural hospitals who didn't have a lot of experience navigating Medicare Advantage plans, having concerns there. So I definitely think that this has always been a concern. There's definitely a perspective on both sides. I think my personal view, at least when I worked in kind of on the plan side, there was a feeling of people don't get it. We're trying to be faster. The provider is not submitting all the information. So we're not just denying it to deny it. We need to make sure we're trying to be a good steward of the dollar. I think that was the feeling there. I think providers and a lot of beneficiary advocates felt that they weren't just double checking and doing that they were going beyond that. They were denying care or just making incredibly burdensome. And so I think that has kind of come to a head. I will say, though, and you alluded to this, Carrie, I think there is agreement across the board, not just in a bipartisan way, but plans, providers. We definitely, at CMS, our changes, we did not have a lot of pushback from plans when we were doing different policies. So I think this is an area where we need to leverage that and really make sure everyone has a seat at the table, because there aren't, easy answers. As you said, that there's financial incentives on both sides, frankly. I think two of the biggest pain points that you hear about are inpatient admissions, as Eddie alluded to, and post-acute care. And those are very high-cost situations. Those are also where the beneficiary is very vulnerable, so the stakes are really high here, and you want to weigh those issues. I think I was thinking about the buckets, and I really think from a call to action standpoint, there's the access, which I think is the most important, which is, are beneficiaries getting the care they need and are entitled to? Because MA, at the end of the day, they are required to provide all Part A and Part B. They can't decide, oh, we think that's low value care, we can't provide it. If there is a fee-for-service requirement in that clinical situation to provide care, they are required to provide it. So, is that happening? Are they just checking that that person meets the criteria, or are they adding additional hoops to go through, which is not compliant? And the burden, are we creating administrative costs and provider burnout and just mucking up the gears of our whole system, which make everything worse? And how do we, and I think there's feelings both on the provider side and the plan side that there's a lot of burden here, a lot of, people on your staff that you would prefer to not have to do this. And then I think the market forces and is another area that I learned a lot about, which is kind of back to those smaller hospitals. Okay, you're seeing a lot of providers leaving MA networks, which is creating access issues, especially in rural areas. So it's becoming this real financial burden, and something that we have to think about from that perspective too, of yes, there's a financial incentive, as I said, both sides, but I do think there's some concerns, and it's creating problems. And so, I think that to me, from a policy perspective, what we really need to focus on are clear rules of the road. Really, what are the rules? What are the clinical criteria? What are the appeals rules? I think we need to work on transparency. I think, as Fred was alluding to, a lot of this, we don't know under the hood what's going on. A lot of it is vendorized, as I like to say. Plans are outsourcing to, Interqual, MCG, and in a lot of the ways, those can help a lot to speed things up, to automate, but at the same time, plans don't have as good a handle on what's happening because they've really outsourced this to third parties. So, thinking about that transparency so we know what's going on, and oversight. I think that a lot of cases, the rules are there, but there's a lot of frustration with regulators who aren't, it's kind of a fair frustration that they're just non-compliant. And so how do we make sure that if we've got the rules of the road right, that people are really following it? And you hear that a lot from plans too, who are like, hey, we feel like our competitor is doing things, and now we have a financial incentive to do behavior we don't want to do, but we're putting ourselves at a disadvantage. So you need oversight. You need to make it clear. So it's not that we're over-regulating. It's that you're helping the market, and you're kind of taking away perverse incentives so that everyone plays by the same rules. And then, the modernization. And I think that there's a lot of hope in just prior auth can make total sense. And I think, as Eddie said, the plans have a big incentive to want to have it be fast, but it's got to be fast and it's got to be immediate. There's got to be less of it. And so there are some rules that CMS has put in place for 2026, 2027 of kind of these applications interoperability. So really making sure that we get that right. It's going to be tricky. There's lots of pros and cons and unanswered questions, but I think there's hope that at least if we modernize this, that will help with some of the access and burden.
Thanks, Molly. To follow on that, Fred, from a beneficiary perspective, has enough been done to make it easier for beneficiaries to appeal when their care is denied? I know it's a process that both providers and beneficiaries have to engage with and worry about. And it is concerning that so few beneficiaries actually appeal when their care is denied. So if you're looking at what has been done so far, has enough been done? And what could make that easier for beneficiaries?
Thank you, Carrie. I think very little has been done, but I love the context of looking at this from a modernization perspective. And so going back to the statistics around, say, roughly 6% of prior authorization services are denied, and that represents millions of services. I think at this point, we don't know all of the services. We don't know how many people that affects. Is it affecting multiple services for the same person, et cetera? And only 8 to 11% of people are appealing those. But when they do, they're winning. So that's 80%. So I think structurally, we have to look at the fact that there's the reconsideration for an appeal. So you submit it, it's denied, the plan gets another attempt. And so we need to know, why are so many decisions being overturned? And I know we're not talking about Part D, but you mentioned that you are going to be looking at Part D. There's structural problems in the Part D appeals process also, especially at the pharmacy counter, since that does not count as a denial. So I think we need more data. To Molly's point, we need more oversight and monitoring and looking at the penalties for plans that are creating blanket denials. And then I think there could be even deeper issues. We don't really know what's also happening in DSNP. So this is the most vulnerable population. So they're enrolled in Medicare and Medicaid, have multiple chronic conditions. And so I think there's just so much more that we can do, but we need more transparency and we need more monitoring of it.
Just to follow up with that, transparency, what is the ideal? I know there's more rules to have plans report, not just the total number of approvals and denials, but to report that on a contract level by type of service, hopefully. What would that do for beneficiaries?
Well, I think the next step would be, once you have that information, we could start to create better tools for decision making. We can make that information easy to understand and put it out there. So as people are making their decisions, whether that's every year during follow-up and enrollment or if that's when they're new to Medicare, they can look at that and say, well, I value this over that, and make a slightly different decision. We also, to your first question, we don't have enough support for people when they need the help with an appeal, and also with the physician's office. So you could look at reimbursement for that. You could look at supporting SHIPs. SHIPs are so underfunded, compared to navigators. So I think there's more we can do just to help beneficiaries.
I think you make a great point, and just learning more about SHIP from my colleagues here, that so many beneficiaries call the number on the advertisement on CNN late at night that's actually a plan or a broker that's getting paid for enrolling people, where they could call SHIP for a totally unbiased person to help them make these choices. Eddie, you talked a little bit about the impacts on beneficiaries when, for example, they have to spend a long time in the hospital waiting to go and get the rehabilitation. What are some of the financial impacts and other impacts on providers and hospitals when those sorts of things happen?
That's a great question. I have looked at the lengths of stay for patients who end up going to, for instance, skilled nursing facility, and compared what happens in fee-for-service and what happens in Medicare Advantage. And I have noticed that over approximately the past 7 or 8 years that there has been a widening of the gap in the length of stay. It used to be less than 1 day difference in patients who would need to go to a skilled nursing facility. In the past 3 years, that difference is now between 2 and 3 days consistently. And so if you look at, roughly the volume, UNC Health is, a medium-sized provider in the state of North Carolina. I think we have somewhere between 2,000 and 3,000 beds across 14 hospitals. That equates to about 2,000 hospital days of where the patients are likely waiting for services to be authorized, where the care is done, where the facility has been identified. And, I'm not a finance guy, but based on how expensive, or the cost of a day, it's roughly probably about $5 million a year that the impact that has to UNC Health. The issue of the inpatient denials and level of care, financial impact is greater. I would estimate that financial impact compared to fee-for-service Medicare to be probably somewhere on the order of $40 million. Now, we need to keep in mind that the patients are receiving the service, but those are important dollars that hospitals need in order to continue providing services to future beneficiaries who have those needs.
Thank you. We have about 1 minute left before we go to you all in the audience, so I hope you're thinking of questions for our panelists. But I'm going to end with you, Molly, because you have been in the trenches You have been finalizing rules. You've been proposing rules. If you could do something that, kind of hard because I know you have done a lot of good things, but if you could build on that with one or two things that you really think could move the needle on protecting the industry and protecting beneficiaries, what would you do?
Yeah, I think it's transparency. I think that, I viewed my job, and I think, if you're a staffer here, you should view your job as to call balls and strikes, right? Like, we are all here. We want beneficiaries to get the care that they want. We want the system to be efficient. We don't want low-value care. But we got to call balls and strikes. And I think that there are some strikes happening where, for example, one large MA plan said that, a certain rule, if it were to change regarding inpatient admissions, would be worth like $3 billion a year. Okay, so that cuts both ways. That means, okay, if there are changes and you don't do it carefully, there could be real cost impacts. Their bids would go up, their supplemental benefits would go down, it would impact beneficiary choice. But it also begs the question, well, is that $3 billion of admissions that aren't happening that should? So the stakes are just incredibly high, and I think that we don't want to get that wrong on either side. But sitting in my old seat, we would hear from providers, we would hear from plans, and it was very difficult to call those balls and strikes. So I think that both regulators need that, and I think that stakeholders need that to really be able to show, because usually the answer is somewhere in the middle. And I think that we need AI tools to go in and look at the data, hotspot things. Are there areas where we really have issues of beneficiary harm? Are there issues? We're seeing a lot of kind of denials after the fact that the Benny access, they got their care, but now the hospital's not getting payment or it's being downgraded. So do we have big issues there? If I was kind of queen for the day, I think having, more transparency, more data tools, would be great. And we're about to embark on the great unknown that is AI. And, CMS had some policies to get at blanket denials, which I think were a real concern, especially in the post-acute space. But there's a lot of great hope with AI and with making things faster and smarter and clinical support tools. So, I think that we need the data so that we can kind of be able to have oversight in this great unknown world that's really going to be taking over healthcare.
Thank you. Now we want to open it up to you all. We'll have our friends from Burness will come with microphones, but gentlemen in the camel, you were the first to raise your hand.
Tom Davey, did my DRPH at GW, but more importantly, I turned 64 in January, which means I'm approaching this from two different and colliding perspectives. So, Fred, can you give us, those of us who are Medicare in the very near future, 2 or 3 good sources for decision making?
Absolutely.
There's a plant, right?
Well, first, I'm going to plug the Medicare Rights Center. So we have a terrific website. It's called MedicareInteractive.org, and you can visit that for Medicare information. I know you know this, and I'm sure you know this, but many people are surprised to learn that they have to enroll into Medicare through Social Security. So Medicare's website has vastly improved over the years. And so Medicare.gov has solid information. And 1-800-Medicare and your local SHIP also provide very good Medicare information. I think what you will be surprised about is that you're not going to receive a notice about your Medicare eligibility from the federal government. And so there is a piece of bipartisan legislation, Benny's 2.0, which would require the federal government to let people know as they're approaching age 65 that they're eligible for Medicare, but most important, what are the consequences of not enrolling, like lifetime penalties, et cetera.
Okay.
I recently learned 1-800-Medicare gets 24 million calls a year, which blew my mind. It's a lot.
Wow.
A lot of need.
Can we get the microphone up here? And if you could introduce yourself.
Megan Anderson Brooks with Innovation Policy Solutions. So I come from laboratory testing space, so thinking like genetic testing to inform personalized medicine care. And I've started digging into prior auth and what the coverage determination process looks like for them. And I just, one, thank you so much for sharing information and for starting this initiative. I'm very excited about it. I have to say I was very encouraged by the recent MA rule, proposed rule, and talking about alignment between Part B and Part C. And I was encouraged that CMS is acknowledging that there might be instances where there is an alignment. So for instance, seeing situations in laboratory space where you have national coverage determinations, but you're getting denials in Part C with MA plans where that would just be covered under Part B. So I appreciated your comments about enforcement. And something I'm hearing from providers is that they don't feel like they have a good way of engaging with CMS about some of the actions and activities that they're seeing that they're concerned about, especially when it's happening time and time again. So I was curious about your thoughts on that. And then I also wanted to raise that my understanding, listening to them, is that the appeal process isn't working well for them. And so even situations where they'll, much like in the hospital, they'll just perform the test. They know patients need that information to inform their treatment plan, but then it gets kind of stuck in level 1 appeal situation, and it doesn't get bumped up to level 2. And so I was just wondering if you have thoughts about solutions that we might think about that could benefit everybody, and both on enforcement and then making sure that the appeals process is working well.
I can take the beginning part, and then maybe you can take the appeals part. One thing that might be helpful that you alluded to make sure that everyone is following is that one of the things that CMS did, MA has always had to provide the same A and B benefits as fee-for-service. Before recent rulemaking, CMS allowed plans and kind of sub-regulatory guidance to essentially say what that means, because at the end of the day, fee-for-service is not a perfect recipe because there isn't the same incentives to have utilization management. So in a lot of situations, the rules of the road aren't super duper clear. So you alluded to a national coverage determination, there's local coverage determination. So those say, okay, in this clinical situation, you have to do this. That does not exist in every single situation. So what CMS did is said, okay, if there is a national coverage determination or local, you have to follow those rules of the road from fee-for-service. But in situations where there aren't, which is a lot of situations, we're going to make it very specific how you fill in those gaps. So, you have to use widely used practice guidance, you have to use research. So you can create your own clinical criteria. It has to be transparent. So I think that's where some people are saying, where there are clear national coverage determinations, clear rules of the road from fee-for-service, people aren't complying, and that's an oversight issue. It's a little bit messier when you're having to have clinical criteria. That's where, okay, you need to make sure that the rules are aligned. So I think it's a fair point. I think these are all very new. That's another thing. It's not a satisfying answer, but these are changes. It takes some time for compliance. Again, plans work with vendors. So I think it's important to know that a lot of these rules went in place 2024, 2025. So I think we're all going to have to, but usually there's iterative changes that need to take place. I will say CMS definitely hears a lot that providers don't have a good way to appeal, that it's more of a beneficiary. I think they're thinking about ways, but defer to you on kind of those appeal frustrations.
Yeah, the burden really falls on the beneficiary. A few years ago, we followed up with a number of helpline clients, and we calculated the amount of time that the beneficiary and the physician's office spent on trying to process an appeal, and it was in double digits. And so in some cases, the initial response from the beneficiary is to skirt the process entirely if they learn about it and just try to disenroll from the plan. There are some circumstances where provider systems also are encouraging people to disenroll from the plan. Just to step back and to look at post-acute care for SNF stays, how is it across different types of medical diagnoses that the basic approval is just 2 weeks. And so we've seen that kind of attempt at shifting, but most people are locked in a plan and can't get out of it. I think on the Medicaid side, you have aid continuing when someone is receiving a service. I think one thing that could be helpful is if a plan hasn't processed an appeal timely, then maybe the default is the service is deemed approved. So I think that could be one approach.
And if I could add one thing that, I have limited exposure to the lab world, but what you're describing is a situation where the service is completed. And so if the beneficiary received that service in network, the beneficiary would not have appeal rights under current CMS interpretation 422.562C2. So the appeal rights that you're probably referring to are the provider's appeal rights, which are governed by the contract. And that gets into what I think an issue that frustrates providers is, why is the contract the place to dispute a Medicare coverage benefit? Like, I can understand, we should be paid $10, you paid us $9. That's a contractual issue, but why is the contract the place for a Medicare coverage decision?
That's a great point. On here.
Thank you. Jenny Whitman from the Alliance of Community Health Plans. Thank you for this event today. This is great. Molly, you brought up AI, and it's sort of the hot topic of the day. And I'm also just curious as to where you think CMS might be going. This is sort of a question for the whole panel, where you think CMS might be interested in going with AI and prior authorization. Some commentary came out in the last couple of years. Fred and Dr. Hu, also curious to see what you're hearing from a beneficiary's perspective, but then also on the provider side, what are clinicians thinking about AI and prior authorization? Is there hesitancy? Are there concerns? Is there eagerness because they think it will simplify a lot of the processes? Would love to hear from all three of you on that perspective.
I can start. I don't know what CMS will do, but I think that, when I was there, a core thing is that no matter what AI is doing, it needs to be compliant with the rules. So I think that, for example, the situation where there was blanket denials, or there were concerns about blanket denials in the post-acute space, the thought there was, okay, a data system was taking 7 million claims and saying Mr. McGillicuddy, with his clinical criteria, probably needs 10 days in a skilled nursing facility, and on day 10 will get kicked out. It's a Medicare requirement that on day 10 you have to check, and if Mr. McGillicuddy still meets the need for that level of skilled nursing, that you have to keep Mr. McGillicuddy there. So you can use that AI, and it's probably a helpful predictive tool for the prescribing, discharging physician to say, okay, this is usually what this person needs, but it wouldn't change the need on day 10 to still. So I think that number one is just like the backbone is having all these rules, and then you layer on top AI. I will say from my personal, not speaking for CMS view, I think it'll be very difficult for CMS to be experts on AI, to have people in the building who can look under the hood. My understanding is that there's third parties being developed who are experts. They are, not for profit. They're at academic institutions, and they could be experts in this. And so maybe it's a situation where CMS says, okay, MA plan, you have to be certified. Your AI technology or the vendor you work with has to be certified by, it's almost like lead certification. You have to be certified by one of these three, approved. So I think that might be a way where we can make sure that CMS, like the government, there's a lot of things the government cannot do, but maybe outsourcing. So thinking of creative ideas like that, I think has some promise.
Molly, I want to ask, you earlier alluded to plans that outsource or vendorize their prior authorization processes to outside organizations. Does that complicate, if the outside organization is using AI, how does that complicate how the plan kind of interacts and what CMS can do?
Yeah, what's difficult for CMS does not have jurisdiction over third parties. So, when we were doing marketing work, this was, tricky because essentially the regulatory, the Hill can do whatever they want, but a regulatory authority is through the plan. So the plan has to make sure that they're, who they work with is compliant. So that's a challenge. I think, and I have plan friends in the room who can keep me honest, but I think there's been a lot of education at plans, but I think behind closed doors, plans would admit to you, they kind of out of sight, out of mind did this, especially a smaller plan, not out of anything nefarious, but it's complicated. And so, in one of my jobs, I was trying to do some work to be like, okay, could we come together as plans and say, in these situations, we don't need prior auth, just to decrease the volume. And I found that a lot of plans just didn't have a good understanding of what their own prior auth policies were because they were so vendorized. And so I think that has changed. I think some plans have pulled it in-house, but I think that has been a problem. And part of it is maybe a little plausible deniability, you can kind of say, but I think that at the end of the day, the plan is, who is being regulated, and they need to make sure that they're compliant. But I do think, and I think any policy solutions need to bring those vendors to the table. They're very smart on these issues. We had good experiences working with them, so they're certainly not, bad actors necessarily. But I do think that it presents challenges.
Mm-hmm. We have a gentleman here.
Michael Greer, NCQA. I'm just thinking about the prior authorization rules that were finalized and changes that we may see on a national level over the next 4 years. Pivoting to states a little bit, what do you think states can do around prior auth, not just for Medicare, but more broadly when we're thinking about insurance? I know places like California have finalized some state rules and state legislation around prior auth requirements for all health plans. But more broadly, what do we think states can do to support the transition and improving prior auth procedures beyond just kind of legislating the actual rules that we've seen? What other ideas are out there do we think that states might be able to do or might be poignant for states to pursue over the next couple of years to ensure we're improving healthcare?
I mean, one thing that we observed as part of the financial alignment initiatives was there was greater communication between CMS and the state Medicaid agencies. And the states that were participating were putting resources to that. And so there has been more oversight and there has been more monitoring. So I think however we can resource that, I think that's important. I think states do have the ability to collect that data and to monitor it, and then also, use various vehicles to require plans to be doing certain things. Maybe that's through the SMAC. And, on the topic of AI is so broad. I think we're using that word now, but for many years, entities have had proprietary software to help with their decision making. And we know that in states, the use of that software makes decisions. And maybe it gets it right, who knows, 50% of the time, 75% of the time, but we have to really look at when it's not getting it right. And so I think states have the ability to dig into that, especially if they're with DSNPs and with the Medicaid dollars too.
Yeah, I would just add, I think states are frustrated because, as you know, they don't have the jurisdiction over MA. So I think, we were getting a lot of pressure at CMS on marketing issues from states. And I think that can be helpful to say, hey, we don't have the regulatory jurisdiction here, but we're getting calls at the insurance commissioner's office. We need better data. We need better tools. We need to know what to say to the people that we serve. I also think some states, folks would know better than me, but a Rhode Island, I think, banned prior authorization in behavioral health, let's say. They have data there. So could that inform thinking at, the legislative level where, okay, you can't actually make changes that impact MA because it's federally regulated, but can you learn from states of unintended consequences, pros and cons? California, I think, as you alluded to, had kind of standardized the method with which you do prior auth. Again, what can you learn from that to potentially federalize? So I think that there's both pressure, kind of political pressure, especially for transparency, but also learnings that can happen.
Right here.
Hi, I'm Hanan from Georgetown Center on Health Insurance Reforms. I wanted to go back to the earlier question about AI use, and I would love to hear the consumer and provider perspective on how how would that impact care? Are we expecting that to increase, decrease quality, place more barriers on patients and providers? I wasn't sure if either Fred or Dr. Hugh, you had any perspective on that, but if you do, it would be great to hear.
Well, one thing that I've been thinking about is first trying to understand what constitutes AI. So we're familiar with the large language models, ChatGPT, et cetera, but very well-resourced businesses and companies have access to these tools when other entities do not. And so, say, for example, nonprofits, maybe even researchers just don't have access to these tools. We don't even know what they are. But I do think there is potential to do good with them. Say, even from an appeals perspective, if we, had access to a AI tool that could maybe help it, analyze a bunch of information that we've received from the beneficiary to, help a person with appeal, that could be something positive. But I think what's concerning is there's an imbalance around who has access to these tools, and we have no idea how they're really being used.
So more transparency. Go ahead.
Just really quickly, because I know that we need to keep on schedule, but one of the most exciting things for providers is the ambient listening software that AI facilitates, and the ability to more accurately and in real time transcribe the conversations between the clinicians and the patients. I know there are many providers that may be seeing 20, 30 patients a day, and then they go home and they write all their notes, at the end of the day. And, how well can you really remember every individual interaction? It's, they're doing the best that they can. And so ambient listening, I think, is a huge opportunity to not only improve the quality of care, but also make it more timely and also alleviate some of the physician burnout issues. There are some areas that providers are looking at potential for AI. We're not at the point now where we have Star Trek, where we can just hover over a patient and it kind of tells us what's wrong. So hopefully that will come one day.
You'll be out of a job, though.
That's okay.
I think privacy is the big concern. So, right now you just don't want to take somebody's medical documents and feed them into an LLM, or, so we need to really, really think about privacy.
Well, we're at time, and I've been instructed that CHIR ends on time, and so we're going to get you all back to your offices and your life. But I want to thank our panelists today for this discussion. I think we've really been able to identify some topics moving forward. Some ways that we can move forward in this time of transition that can improve this process and ensure that beneficiaries are getting the care that they paid into and that they were promised. So I want to thank all of you for coming and talking about Medicare Advantage at 8:30 in the morning. Way to go. And stay in touch with us at MPI. We are really, really interested in talking to all of you and learning about what you're doing, providing technical assistance and policy analysis. And we just want you to stay in touch, sign up for our mailing list so you can see the blogs and issue briefs that are coming out. And we will see you next time. So thanks for being here.